Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today, we're really getting into something critical in clinical practice, especially for you listening, the surgeons, the doctors dealing with this every day. We're talking about the accurate diagnosis of anal and perianal fistulas.
Absolutely. And it's fascinating just how much precision this area demands. I mean, getting the diagnosis right isn't just ideal, it's essential. A mistake here can lead straight to, well, real patient suffering. Think persistent recurrence or even devastating issues like fecal incontinence.
That's a huge concern.
Yeah, and maybe even more critical is missing something serious underneath, like Crohn's disease or, heaven forbid, a malignancy hiding there.
Okay, so the stakes are clearly high. Consider this deep dive then, your kind of rapid-fire guide, a thorough look at the diagnostic essentials. Our goal today is really to equip you, the clinician, with a clear, actionable framework based on solid sources.
Exactly. Tools to help prevent those recurrences, protect that vital sphincter function, and crucially, catch any underlying pathology that might be lurking. So, where should we start?
Let's start right at the beginning, where so much in medicine begins. The patient's story. The clinical history. It's not just about listening, is it? It's knowing what to listen for. What are those key symptoms that should immediately put clinicians on alert?
You're absolutely right. The history is, arguably your most powerful initial tool. You're really tuning in for persistent discharge. Is it pus-like, purulent, serolous, or, and this is a big one, is it fecal?
Fecal discharge sounds pretty definitive.
Oh, it is. It's basically pathognomonic, right?
Yeah.
It tells you there's a direct connection to the bowel. That immediately signals likely a more complex situation, a higher tract maybe. It just ups the urgency.
Makes sense. What else symptom-wise?
Then there's intermittent pain, often worse when the patient sits or during defecation. But interestingly, it might actually lessen after a spontaneous discharge of pus or fluid.
That decrease in pain after discharge, that's quite a specific clue, isn't it? Does that tell us something mechanically?
Yeah, it strongly suggests, built-up pressure from pus has been released. It gives temporary relief, but the underlying problem, the fistula tract itself, is obviously still there.
Right, the relief is temporary.
Exactly. And speaking of pressure and buildup, perianal swelling is another major sign. The sources we looked at mentioned that something like 40% of recurrent perianal abscesses actually precede the formation of a fistula.
So swelling equals potential fistula.
It's a strong indicator, yeah. You should definitely be thinking fistula if you see recurrent swelling or abscess formation. And of course, all that chronic drainage often leads to itching, pruritus, or just general skin irritation down there.
Beyond those immediate symptoms, you mentioned red flags in the history, things that might change your whole diagnostic approach. What are those critical points clinicians need to ask about?
This is crucial because, well, not all fistulas are created equal. You absolutely have to ask about any history of Crohn's disease.
Yeah.
Also, tuberculosis, any prior pelvic radiation or known malignancy.
Why are those so important?
Because these conditions can either cause fistulas that need very different management, or they can mimic them. You don't want to miss that. And also ask about systemic symptoms, things like unexplained fever, weight loss. Those always signal something potentially more serious going on.
And what about past surgeries or, say, childbirth trauma? How does that factor in?
Hugely relevant. Any prior anorectal surgery, especially if they've had an abscess drained before or significant obstetric trauma, can predispose someone to developing a fistula.
Okay.
And the sources really emphasize this. If a fistula recurs, it's very often a sign that the initial surgery either missed the internal opening, the source inside, or it didn't fully map out a complex branching tract.
So recurrence is a big clue. You're dealing with something trickier.
Exactly. It tells you to dig deeper.
All right, so after gathering that crucial history, the next step is the hands-on part in the exam room, the physical examination. This is where things really start to take shape. Let's begin with just looking inspection. How do you position the patient, and what are you scanning for visually?
Good positioning is key for a good look. The sources suggest either the left lateral position, lying on their left side, or the prone jackknife position, whichever gives you the best view.
And you're looking for?
Primarily, you're looking for external openings, the EOs. Note exactly where they are. Anterior, posterior, midline, off to the side. And crucially, are there multiple openings?
Multiple openings suggest something specific.
Yes, definitely raises suspicion for a more complex fistula, maybe even a horseshoe fistula, which kind of wraps around.
Press.
That changes your surgical planning significantly. And of course, look for signs of inflammation around any opening, redness, swelling, induration, maybe some granulation tissue.
Okay, inspection done. Then we move to palpation, actually feeling the area. What are we trying to find with touch?
With palpation, you're trying to feel the fistula tract itself, the induration. The technique is usually gentle compression, maybe between your thumb outside and index finger inside the anus, or just externally. You're feeling for a sort of firm cord-like structure under the skin.
Like a little rope.
Kind of, yeah. That's the fibrous tract. And importantly, if you find a specific spot that's exquisitely tender when you press, that might point towards an undrained pocket of pus, an abscess, rather than just the tract itself. Needs different handling.
This naturally leads us to the digital rectal exam, the DRE.
Indispensable, right?
Yeah.
Getting that internal perspective. How do you approach finding the internal opening, the IO, during the DRE? Absolutely critical, the DRE. You're carefully feeling inside the anal canal for what's often described as an indurated pit, maybe a little nodule. And you're focusing your search along the dentate line.
The dentate line being that key landmark.
Exactly, that junction between the rectal mucosa and the anal skin. The vast majority of internal openings are found right there. And this is where a classic rule really helps guide you.
Ah, you must mean Goodsall's rule. Always good to have a refresher on that one. Can you break it down for us?
Yeah, Goodsall's rule is like your basic GPS for predicting the fistula's path.
Mm-hmm.
Imagine drawing a line across the anus, a transverse line, dividing it into front and back. If the external opening, the EO, is anterior to that line towards the front, the tract usually runs straight, radially, like a spoke on a wheel, directly into the anal canal to find the IO.
Simple enough for the anterior ones.
Generally, yes. But if the EO is posterior to that line towards the back, the tract usually takes a curved path, often looping around to an internal opening in the posterior midline, right at the back, typically at the 6 o'clock position if you think of the anus like a clock face.
Interesting. So posterior means a curved track, usually to the back midline.
That's the general rule, yeah. It's surprisingly useful for anticipating where that IO might be.
But like all rules in medicine, there are exceptions, right, to keep us on our toes.
Precisely. The main exception involves those anterior openings.
Oh.
If an anterior EO is quite far from the anus, say more than 3 centimeters away,
Okay.
it might actually defy the rule and track posteriorly, curving around to that posterior midline IO, just like the posterior openings do. So distance matters for the anterior ones.
Good nuance to remember. What else during the DRE besides searching for the IO?
Oh, very important. Assess the sphincter tone, both the resting tone and the squeeze pressure. The source material calls this critical for surgical planning. You absolutely need to know the baseline muscle function before considering any surgery that might affect it.
To avoid incontinence issues down the line.
Exactly. And one more thing, feel above the anorectal ring, higher up. Any induration or tenderness there might suggest a supralevator extension, meaning the fistula goes up high above the main sphincter muscle complex. That's a more complex scenario again.
Okay, DRE covered. Sometimes we need direct visualization, maybe with an endoscopy or proctoscopy. What's the goal there, and what's the deal with probing the tract? I hear that's a bit controversial.
Yeah, so endoscopy or proctoscopy lets you get a direct look inside the anal canal. The main goal is to spot and confirm that internal opening, usually right at the dentate line. And it's pretty effective. You can find the IO visually in, say, 90% of cases this way.
That's quite high.
It is. Now, probing. You're right, it's controversial. The sources say if you do probe, it absolutely must be gentle. You'd use a thin, malleable fistula probe, trying to guide it from the external opening towards where you suspect the internal opening is.
But gently.
Very gently. And crucially, the advice is generally to avoid probing altogether if there's acute inflammation or if you think it's a complex tract. There's a real risk of forcing it and creating a false passage.
Ah, creating a new problem.
Exactly. A false tract just complicates everything down the road. So extreme caution or avoidance is key, especially if you're not sure of the path.
Understood. So sometimes the office exam, even with endoscopy, isn't quite enough, or maybe it hints at complexity. We need to go beyond the exam room. What's the next step, the sort of first-line investigation when things aren't straightforward?
If the office evaluation doesn't give you a clear answer, maybe you can't find that IO confidently, or if you suspect it's a complex fistula, high, recurrent, multiple tracts, then the next logical step, and really the first-line investigation in these cases, is an examination under anesthesia, or EUA.
Right, the EUA. It sounds like a bigger step, obviously involving anesthesia. What makes it so indispensable in these situations? Does it do more than just diagnose?
That's the beauty of it. The EUA has this fantastic dual benefit. First, it allows for a definitive diagnosis. The patient's relaxed under anesthesia, so you can perform a much more thorough exam, palpate deeply, probe carefully if needed, maybe inject something like methylene blue or hydrogen peroxide to map the tract without causing pain or spasm.
So better mapping.
Much better. And second, critically, it allows for simultaneous treatment once you've clearly defined the fistula's anatomy.
You can act on it right there.
Exactly. You can often proceed immediately with the appropriate surgical procedure, whether that's a fistulotomy, which means laying the tract open to heal from the base up, or placing a seton drain if it's a more complex fistula involving significant sphincter muscle. So you get diagnosis and treatment in one go.
That's efficient. Now let's talk imaging. We have amazing tech these days. When EUA isn't the first step, or maybe you need even more detail before an EUA or surgery, what are the key imaging tools?
When you need that detailed anatomical map, especially for the tricky cases, endoanal MRI really stands out. It's widely considered the gold standard.
Gold standard for which types of fistulas specifically?
It's particularly valuable for complex fistulas, recurrent ones, if you suspect Crohn's disease is involved or if you think there might be that supralevator extension we talked about. Its accuracy is high, reported around 93%, and it gives you this incredibly detailed picture of the tract and its relationship to the sphincter muscles.
Seeing the sphincter involvement clearly seems paramount.
Absolutely. That detail is vital for planning a surgery that cures the fistula without damaging continence. MRI gives you that roadmap.
Okay, MRI is the top tier. What about endoanal ultrasound, EUS? Where does that fit in?
EUS is another really useful tool, especially perhaps for simpler or lower fistulas. It's also good for helping pinpoint the internal opening. One advantage is its dynamic capability. Sometimes they enhance it with hydrogen peroxide, which creates little bubbles you can see tracking through the fistula in real time.
Oh, interesting.
Yeah, and it can often be done right there in the clinic or office setting, which is convenient. Maybe not quite as detailed as MRI for very complex anatomy or abscesses high up, but definitely valuable.
What about fistulography? That's an older technique, right? Injecting contrast and taking x-rays. Is that still used?
You know, the sources are pretty clear on this. Basically, avoid fistulography. It's generally considered obsolete.
Obsolete. Why is that?
Its accuracy is just too low, it misses a lot of tracts, high false negative rate, and it doesn't show the relationship to the sphincter muscles nearly as well as MRI or EUS. So, yeah, not really recommended anymore.
Good to know. Okay, one more imaging modality, pelvic CT scans. Is there a role for CT?
CT isn't usually the first choice for mapping the fistula tract itself. Its main role comes in if you suspect a complication, like broader pelvic sepsis or maybe an underlying malignancy. It's better if we're looking for larger pelvic abscesses or other pathology in the pelvis that might be related to or causing the fistula, less about the fine detail of the tract itself.
Got it. So CT for the bigger picture complications, MRE-US for the tract details. Now, what about specific situations? If you have a strong suspicion of Crohn's disease, what's the diagnostic approach then?
Right, if Crohn's is high on your list, maybe a young patient, complex fistula, other symptoms, you need a combined approach. The recommendations usually involve getting that MRI to see the fistula anatomy clearly, plus a colonoscopy to look for inflammation in the bowel itself, and checking inflammatory markers like C-reactive protein, CRP, or fecal calprotectin.
So imaging, scope, and labs to confirm the underlying IDD.
Exactly. It's a multi-pronged approach to confirm Crohn's and guide management, which is very different for Crohn's-related fistulas.
And what about those frustrating recurrent fistulas? What's the key investigation to figure out why it keeps coming back?
For recurrence, MRI is again your go-to investigation. You're essentially looking for what was missed the first time. Did they miss the true internal opening? Is there an overlooked secondary tract like a horseshoe extension branching off? Or is there a hidden abscess, maybe a supralevator one, that's feeding the fistula? MRI is the best tool to find those culprits.
Makes sense. Need to find the hidden source. What if you identify what seems like a high fistula, or one clearly going through the sphincters, like an intersphincteric or transsphincteric one?
For those high or clearly sphincter-involving fistulas, MRI or EUS become absolutely crucial. You need to precisely define how that tract relates to the sphincter muscles, particularly the puborectalis muscle sling, which is vital for continence. Understanding that exact anatomy is non-negotiable before you plan any surgical intervention.
Because cutting the wrong muscle has major consequences.
Devastating consequences, yeah.
Okay, this brings us neatly to classifying these fistulas properly. The Parks classification. You hear this mentioned all the time. Why is it so fundamental for surgical planning? And can you give us a quick rundown of the main types?
The Parks classification really is the surgeon's essential roadmap. The source material calls it critical for surgical planning because it categorizes fistulas based on their path relative to the sphincter muscles. And knowing that path dictates the entire surgical strategy.
Okay, so what are the types?
There are 4 main types. The most common, accounting for maybe 70% of cases, is intersphincteric. This means the tract runs in the plane between the internal sphincter muscle and the external sphincter muscle.
So between the layers. Seems relatively straightforward.
Often, yes, compared to others. The next type, making up about 25%, is transsphincteric. Here, the tract actually punches through both the internal and external sphincter muscles.
Ah, crossing the external sphincter. That sounds riskier for continence.
Definitely. It requires much more caution surgically. Then you have suprasphincteric, which is less common, maybe 5%. This tract loops up and over the entire sphincter complex, including the puborectalis, before heading down to the skin. So it's a high fistula.
Looping over the top. And the rarest one.
That's extrasphincteric, maybe only 1% of cases. This tract originates higher up in the rectum, completely bypasses the entire anal sphincter mechanism, and goes straight out to the perianal skin, often related to trauma, malignancy, or specific infections.
So understanding which of those 4 paths the fistula takes is key to choosing the right operation.
Absolutely essential. It determines whether something like a simple fistulotomy is safe, or if you need a more complex sphincter-sparing approach, like placing a seton or performing a flap procedure.
Right. We've gathered history, done the exam, maybe got imaging, classified it. How does a busy clinician practically put this all together? Is there a kind of flow chart or algorithm they can follow?
Yes, absolutely. There's a pretty logical flow. It starts, of course, with your clinical suspicion based on that good history and thorough physical exam we discussed.
Okay, suspicion raised.
That leads you to your initial office evaluation. Inspection, palpation, DRE, maybe endoscopy. Now, here's the first major decision point.
What's branch point?
If in the office you successfully identify the internal opening and the fistula seems straightforward, likely a low intersphincteric or low transsphincteric, what you call a simple fistula,
Yeah.
then you can also proceed directly to planning treatment, typically a fistulotomy, assuming the patient's sphincter function is good.
But what if you can't find the IO or it looks complex?
That's the other path. If the internal opening remains elusive, or if there are any features suggesting complexity, multiple openings, high location recurrence, suspected Crohn's, then your next step should be that examination. Under anesthesia, often combined with an MRI either before or decided upon during the EUA.
EUA plus MRI for the tough ones.
Exactly. And there's one parallel pathway. If at any point you have a significant suspicion for Crohn's disease that triggers the specific Crohn's workup we mentioned, the MRI, colonoscopy, and the inflammatory markers.
Okay, that provides a clear pathway. But even with a pathway, things can go wrong. What are the common pitfalls clinicians really need to watch out for? The mistakes that lead to recurrence or complications?
Knowing these pitfalls is maybe just as important as knowing the steps, because they're traps you can fall into. The absolute biggest one, according to the sources, missing the internal opening.
Still number one.
Still number one. It's cited as the main reason for failure or recurrence in something like 80% of cases. If you don't deal with the source, the problem will just come back.
Makes perfect sense. What's another common trap?
Overlooking a horseshoe tract. Remember those complex fistulas, often starting posteriorly, but with extensions wrapping around to the sides.
Right.
If you only treat the main posterior component and miss those lateral extensions, you haven't cured the patient. Recurrence is almost guaranteed. You need to identify and manage the entire horseshoe.
So, incomplete treatment of complex anatomy. What about those historical red flags we talked about earlier?
Ignoring them is a major pitfall. Failing to recognize the significance of a history of Crohn's or prior malignancy or pelvic radiation. Treating those situations like a standard simple fistula can lead to disastrous outcomes because the underlying cause and the required treatment are fundamentally different.
You can't just do a simple fistulotomy if it's Crohn's, for example.
Absolutely not. That can make things much worse. And the final big pitfall, underestimating sphincter involvement.
House.
Not accurately assessing how much muscle the tract crosses before surgery, or choosing an operation like fistulotomy that cuts too much muscle for that particular patient's anatomy or baseline function. This is what leads directly to post-operative incontinence.
It's a devastating outcome.
Truly, which is why careful assessment, classification like Parks, and often imaging like MRI are so vital to plan a safe, effective, sphincter-preserving surgery whenever possible.
This has been incredibly valuable, really breaking down the diagnostic journey. So for our listeners, the busy doctors, the surgeons, let's distill this. What are the absolute must-know take-home points from this deep dive?
Okay, the key nuggets. First, history and physical exam are your foundation. You can diagnose maybe 70% of fistulas clinically with just these tools done well.
Foundational skills still key.
Absolutely. Second, for the complex or recurrent cases, EUA plus MRI is your gold standard combination. That gives you the definitive map.
Got it. Gold standard. EUA plus MRI for complexity.
Third, a crucial warning. Never force probing. The risk of creating a false passage and making things worse is just too high. Gentleness is paramount, or just avoid it if unsure.
Never force probing. What else?
Fourth, always suspect Crohn's, especially in younger patients presenting with complex or atypical fistulas. Keep that differential high on your list.
Suspect Crohn's. And finally,
getting that accurate Parks classification isn't just academic. It fundamentally dictates your surgical approach and is essential for balancing cure with preserving continence.
excellent summary. This really underscores that a systematic approach is everything here, doesn't it? Combining thorough history, careful examination, and then using advanced tools like EUA and imaging judiciously. That seems to be the path to avoiding complications and achieving a cure.
Precisely. It's about being methodical, understanding the anatomy, identifying complexity early, and always keeping the patient's long-term function, especially continence, at the forefront of your planning. And that EUA really remains a cornerstone for difficult cases, providing both clarity and the chance for immediate action.
So, a final thought for you, our listeners, as you head back into your clinics and operating rooms. Beyond just getting the diagnosis right for this one episode of care, maybe reflect on this. How can you leverage these diagnostic insights more effectively across your practice? How can we better use this knowledge not just to treat the current fistula, but to contribute more significantly to long-term patient well-being, reducing the chronic burden this condition can impose? Something to think about.
A great point to end on.
That's all for this deep dive. Thanks for joining us. We'll catch you next time.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.